Welcome to Own Your Heart Health. I'm Dr. Regina Druz, your holistic cardiologist. This week, we will dive into common heart health concerns, uncovering root causes, and unpacking scientific discoveries and controversies. The information provided does not constitute medical advice. Please contact your healthcare practitioner before making any changes that may impact your health. Hi, everyone. I have a great guest for you today. This is absolutely an episode that every woman who is listening right now must be listening to. And if you are a man listening to this episode, please tell your wife, your girlfriend, your mom, your sister, whoever you have to actually listen to this episode. And the reason for it is that I have a colleague of mine, Dr. Polly Watson, who actually specializes in hormone wellness. Her focus is very much in menopause and perimenopause space. She's a certified menopause specialist through North American Menopause Society. And I first met Dr. Watson when she reached out to me and she said, "Hey, can you tell me a little bit about, what's going on cardiac-wise for women in menopause?" And we had this great conversation. And I said, you know what? I have some very, very specific questions for Dr. Watson. And I'll bet you those questions are sort of percolating somewhere in the back of your mind. And maybe you have heard some terms, maybe not. So I'll give you a little bit of a spoiler alert. The theme of this episode is estrogen dominance, or as you may have heard me talk about it before. I actually call it estrogen explosion, but more on this later. I will explain why it's estrogen explosion. But welcome, Dr. Polly.
Thank you so much for having me. This is going to be really fun, and I just value your work so much. And we are always looking for allies. So even if you're a man listening, we need some allies. We need some advocates. We need some team players. So we're gonna welcome anybody who wants to support women, because there are not enough people supporting women right now. So we're glad for anybody on that team.
I agree. Woohoo. And you know what? I think we as women, definitely value partnerships and collaboration. And I think it's important, the fact that menopause and women's health has been at the forefront of a lot of specialties, including cardiology. We've been working in women's health. We actually have cardiovascular physicians who specialize in women's health. But I think to really appreciate women's health and to do the right thing, we need to bring this integrative functional medicine lens into it. So Dr. Polly, the same question I ask it of all my guests: how did you grow up to be a functional medicine doc and a hormonal specialist? Kind of give us an understanding, where you started and how you ended up where you are today.
So my mom was a huge inspiration for me. She went through menopause at 38. And at the time, nobody was really cluing into that. They just told her that this was all in her head and it wasn't happening. And now we know early ovarian failure has significant neurocognitive effects, significant effects on the skeleton, significant effects on the heart. And so it was really malpractice not to take her seriously, not to evaluate what was going on, and not to treat her. And I just remember I was a high school student at the time, and I'm like, this is ridiculous. Like, my mom would go into the doctor and cry. They would just want to get her out of the room. I mean, it was a disaster. And so I knew I wanted to go into women's medicine. I went into delivering babies, and that was fantastic. But I got menopause certification early and started focusing on that really early in my career. And how I kind of broadened to include functional medicine was I was actually at Menopause Society. And it was back in the day when you could walk up to the front and ask a question, like you didn't use an app or anything like that. And someone walked up and said, my patients are asking about adrenal fatigue. What is that? How can we help them? What is that? And they were like, that doesn't exist. And it was that same silencing, this isn't real, la, 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 la. And I'm like, okay, we may argue about the correct terminology for that. Fine. But people are suffering. Can we get curious? Can we explore that? And so then I found AIHM with Mimi Girardi, and I found IFM. I did some classes with A4M. And so kind of really broadened the scope of thinking about, okay, what are all the lifestyle, what are all the root cause things? What is this adrenal health that people are talking about? And that was just, once you know, you can't go back, right?
That is so true. And I have to tell you, I may have told this story a couple of times, but it was, quite a few years ago. I was very much inspired by some of the senior cardiologists. A lot of them were women, and they were pioneers because they launched the concept of women's cardiovascular health as sort of a separate focus for cardiology. And it's not really a specialty or subspecialty, but it's a recognized facet where a lot of cardiovascular effort and prevention, diagnosis, and treatment is, taking place. And what was interesting, I was a faculty member at the American College of Cardiology, and I was in the faculty lounge. And, American College of Cardiology is a massive organization that essentially defines what cardiology is in the United States and even globally. And I'm thrilled to be its member and, volunteer in various positions. But at that time, I was fairly junior. I was in that faculty lounge and speaking with an extraordinary cardiologist, the one who truly, as a female, put the women's health in cardiology on the map, made it a term, made it something that people know. And I casually mentioned in the conversation that I'm interested in learning how hormones or hormone replacement therapies may be affecting some of these things that we are seeing from our female patients. And this cardiologist, she said, basically, Regina, she said, just talking about hormones in cardiology is a malpractice.
Wow.
And so obviously it's been many years and many things have come and gone. And, there's a lot of this new findings and new thinking. So, and we don't talk like this anymore, and B, like, we don't think like this anymore. Hopefully, my fellow cardiologists, if you're listening to this, you don't think like this anymore. But Polly, so what is the connection? What have you learned? What have you seen as somebody who is focused through this more integrative lens on women's health, specifically this perimenopause, menopause period? Kind of give us the flavor of what those patients are like. What are you seeing, and what are the health issues that we're encountering?
I think there's been a big shift, and I think the shift has been, we were initially talking about hot flashes, night sweats, and vaginal dryness, right? And now I think we're broadening our understanding to think about, hey, when I'm perimenopausal and my estrogen levels are fluctuating, what's happening to my heart? Am I starting to have heart palpitations? What's happening to my mood and my cognition, right? My working memory may take a hit. My language acquisition, what is that word? That may take a hit. What's happening to my sleep? What's happening to my body composition and insulin resistance? Am I starting to, maybe my scale's not really changing, but things are moving around where all of a sudden I lose my waist and I kind of become SpongeBob SquarePants, right? I don't have that hourglass figure anymore. Women may notice from a musculoskeletal sense that they're having a harder time maintaining lean muscle mass and building muscle. So I think we've really had a shift from hot flashes, night sweats, vaginal dryness to brain health, heart health, musculoskeletal health, mental health, and metabolic health. And we're really broadening and recognizing hormones affect every single tissue in our body. So menopause doesn't happen in a vacuum. It's not about just symptoms. And I think the other shift that's so important is there may be reasons to consider hormones that have nothing to do with hot flashes, right? Most women have hot flashes. Hot flashes are a cardiovascular risk, right? We know that women who experience them are at higher cardiovascular risk than women who don't. But as we're learning more, and we don't know it all yet, and we would really love for this research to continue to get funded and not defund scientific research, especially in women's health, that maybe we could protect our brains if we start hormones and we start them before the final menstrual period. What about musculoskeletal health? And what about the musculoskeletal syndrome of menopause and all that achiness and fibrosis and frozen shoulder and all those things? So I just think we're seeing these symptoms affect the whole person.
Hi, everyone. It's Dr. Regina here. I know there are contradictory opinions about nutrition for heart health and longevity. Discussion often gets heated and confusing. There are those who push for low fat, low cholesterol. Then there are fans of a ketogenic diet. There are many anti-meat voices as well, suggesting vegan or vegetarian style of eating. With all the chatter out there on what and how to eat, my team and I decided to create a tool for patients, medical professionals to clear the clutter. It is called Holistic Heart University, and it provides on-demand courses, nutrition and lifestyle resources, information on supplements to make it easier to understand how to make healthy choices for your heart. I'm especially proud of our open office hours for program patients and the Q&A feature where you get to ask your individual questions and put us in the hot seat. Head out to the show notes for the link and use my special promo code to get a huge 20% off on our annual health and wellness subscription. The code is OWNER20, and I'll see you in the office hours. We're seeing an expanded understanding that perimenopause and menopause are actually systemic conditions, right? They are not limited just to the typical things that we associate with hormones, but they do affect the entire body, and they affect critical systems such as cardiovascular system, neurological system, musculoskeletal, and ultimately they affect women's longevity. And the same is true for men, by the way. It's just men don't have this sort of like fall off the cliff type of a circumstance that's been biologically programmed, but it is very true. And so I'm wondering if, so I've been looking a bit into the various associations between menopause and perimenopause and cardiovascular issues, because I have been seeing a lot of these in my practice. Women with arrhythmias, palpitations, atrial fibrillation, all of a sudden new onset hypertension or labile hypertension, left ventricular hypertrophy, certainly lipid abnormalities and insulin resistance and weight gain, especially visceral fat gain, is highly prevalent. And, one of the interesting things, or maybe it's not as interesting, but, it is a new knowledge, is that we have noticed that with the current imaging techniques, we're approaching the threshold where in a routine clinical imaging, because a lot of it right now is still experimental, but in routine clinical imaging, we will actually be able to see the deposits of fat internally around the coronary arteries and around the heart chambers. And this is actually called ectopic adipose tissue, or EAT. And we know that this ectopic adipose tissue could be very inflamed, and there are conditions that are much more prevalent in women. For example, obesity-related phenotype of heart failure with preserved ejection fraction is almost synonymous with being a female. And the role of this ectopic atrial tissue and how it behaves, of course, is very much, clued into the hormonal shifts. So speaking of the hormonal shifts, what are the kind of stages? Like, how would a person, let's say a woman or woman's significant other, recognize that they're in perimenopause or menopause? Can you kind of walk us through, the traditional terminology, right? I know that there's quite kind of this 10 stages of reproductive aging in women, so walk us through it, please.
So I find this extraordinarily frustrating as a clinician, and also as I think my patients do too. So there was something called the straw criteria. And so just, usually we start off with menopause, and we say menopause is the day where you haven't had a period for a year. And then the rest of your life is postmenopause. Okay, fine. We usually talk about postmenopause and menopause synonymously. Fine. Perimenopause is the time of ovarian, kind of progressive ovarian failure, right? For maybe lack of a better term. And just like maybe a better way to think about it is puberty in reverse, right? We don't start our period and our breast development and body odor and body hair, it doesn't all happen as a light switch, right? It happens progressively over several years. And so when we're kind of ramping up reproductively in adolescence, we kind of ramp down in perimenopause gradually. Now, I believe it was the Swan study that looked at different patterns of perimenopause. And so not everybody does this the same, and that can be kind of frustrating. So a lot of times women who are of more adiposity, women with maybe a little bit more fat on board, they may have more of a linear, we're kind of going down slowly. A lot of women who are leaner will often have a giant estrogen spike before their estrogen levels decline. And so in those women, we will often see, like you were saying, the estrogen explosion, right? They come in and they're having Shark Week periods. Their boobs are killing them. They're crying all the time. It's like PMS on steroids, right? And then they'll do that for a few months, and then 2 months after that, they're missing 3 periods in a row. And they're like, it's like Freaky Friday. Which body am I going to wake up in today? And this can go on for 2 to 10 years. So that is a really long time to kind of be in the transition period. So when people are like, oh, well, this is natural, it will just pass. You're asking someone to sort of hang on by their toenails for a decade. That's not acceptable, right? So we've got this perimenopause can last 2 to 10 years. It can have very different patterns. Very, very few women are it's going to have this easy light switch. I had my period was regular, and all of a sudden my period stopped. That is by far the exception and not the rule. Perimenopause from straw is divided into early and late perimenopause. Again, I don't find this wildly helpful. If you're in early perimenopause, your cycles are starting to become irregular. And again, this is helpful for women who haven't had an ablation, who still have a uterus, and who don't have a Mirena IUD, right? So we just wiped out a good chunk of the population right there, and that aren't on any kind of hormonal contraception that's giving them sort of a fake period, right? So our criteria are limited to a subset of the population that's not being hormonally managed and still is able to have a period. And so early perimenopause, the cycles are starting to become irregular, but you haven't missed 2 cycles in a row yet. And then late perimenopause, you haven't had a cycle for at least 60 days. So you've missed 2 cycles in a row. And then women will say, great, I'm in late perimenopause. When is this going to end? And I'll say, about 2 years. And so it's super not satisfying, because it's like, okay, well, 2 years is a long time to be like, what do you mean 2 years? That's a long time. And there's not, we could check AMH, we could check FSH, we could check estrogen and progesterone in the luteal phase, but none of these labs are wildly predictive to say, when is it going to end? And so I think that's sort of frustrating for everybody.
I agree. And I think, the definitions in my mind, having seen women and sort of emergence of these cardiovascular risk factors, right? You mentioned this one study, and this one study did recognize that there's sort of fairly distinct blood pressure trajectories, right? Some women continue to stay normotensive. They've been normotensive before. Some become hypertensive early, some become hypertensive late. But we know that these hormonal fluctuations increase arterial stiffness. And of course, you already mentioned vasomotor symptoms, hot flushes, they are linked to almost 40% bump in the risk of hypertension. So this is very profound. Women continue to die from heart disease as the leading cause of death. 1 in 3 women. We had temporarily had an improvement after many years of dedicated advocacy and focus on women's cardiovascular health. At one point, it dropped to 1 in 4 women, but it's technically right now it's 1 in 3 women that actually die of cardiovascular disease. And majority of women, over 60% have no symptoms prior to their first heart attack. They basically may have some atypical symptoms, and then boom, they have a heart attack. And this is, again, very different from male counterparts. And women continue to have higher mortality after their first MI. Women also continue to have this cluster of syndromes that is sort of unique to perimenopause, menopause, things like spontaneous coronary artery dissection or Takotsubo cardiomyopathy, they're fairly rare, but we recognize them as having some hormonal connection. So it's interesting that you're mentioning that in this sort of personalized pathway, there are times, probably for almost every woman who is kind of going through this perimenopause into menopausal transition, there are times when there is an estrogen surge or relative predominance of estrogen over progesterone. So I call it estrogen explosion. More common ways of calling it is estrogen dominance. So what is estrogen dominance? What do you typically see, and how would you define it? Give us sort of like your take on it.
Okay. So in my opinion, we can have estrogen dominance throughout the reproductive cycle. So we're thinking about just kind of basic 101. Most people already know this. The first half of the menstrual cycle, the follicles. So you've got ovaries. Inside the ovaries are your little eggs. We call those follicles. As they sort of mature and get ready to ovulate, they're making estradiol. Okay. And estradiol is building up that uterine lining in case there's a fertilization, so that there's sort of a landing pad, if you will, in the uterus. There's a nice nest formed, right? So in the first half of the cycle, we're building that lining. Estrogen levels are increasing. The little follicle is maturing, and eventually one of them is going to become the dominant follicle, and it's going to ovulate. When it ovulates, it makes the corpus luteum, and the corpus luteum makes progesterone. So the first half of the cycle, estrogen dominance is normal. That's not abnormal. That's normal. And then the second half of the cycle, we have this lovely rise in progesterone. And so when I think about estrogen dominance, I'm thinking about the balance in the luteal phase. Was progesterone adequate to balance out the amount of estrogen that's there, right? So we could see estrogen dominance throughout the reproductive cycle. So if we have an adolescent, let's say, their hypothalamic pituitary adrenal axis is immature, their brain and their ovaries haven't figured out how to talk to each other yet, they could have anovulatory cycles. They're developing the follicle, right? But we didn't quite figure out how to ovulate that month, or, they're teenagers, they're stressed out, their sleep screwed up, their nutrition screwed up, like all the things. And then they're making estrogen without progesterone. So that kid may have really bad PMS. They may have a little irregular bleeding, right? So we would see that. Fast forward to, let's say, into the reproductive time, let's say when women are typically having babies, another condition we think about is PCOS, right? Polycystic ovarian syndrome is another sort of estrogen dominant condition. The citations vary, but this can be between like 5 and 15% of the population. It's really common. It's a condition where we have insulin resistance. The ovaries aren't ovulating regularly, and we're making estrogen, but we're not ovulating regularly, so we're not making enough progesterone. And then PCOS, with that insulin resistance, it's kind of a double whammy, because what's happening in that insulin resistant state is we're putting fat in our liver. So we're compromising our metabolic health and our liver health. Our liver is where we detoxify estrogen. So it's kind of a catch-22, right? And then we mentioned this already. If we move forward in the reproductive cycle, now we're in perimenopause. The ovaries only get all the eggs you're going to have when you're born. You don't get any more eggs, right?
Right.
And
you come
they're little hard. They're just getting older and tireder and tireder.
You come preloaded with all of your assets.
That's right. We're preloaded. And so, mid 40s, but this could happen like for my mom, right? She was done at 38. So it's not always very cut and dry. There's a pretty big range there. So, sometime in your 40s for most people, your ovarian quality has been going down, right? Our ovarian quality has been going down since we were 35. Now we're in our mid 40s. We might miss some ovulations. And then what is our brain doing? Our brain is saying there's not enough estrogen on board. My ovaries are starting to fail. I'm going to my brain is going to start sending follicle stimulating hormone. My ovaries, come on, ovaries, work harder, right? So you've got this real push to get the ovaries going, and then they just can't quite get there. They just can't quite ovulate, or when they do, the egg quality is poor, and so we have low progesterone. So we can see this estrogen dominant, poor progesterone at different stages through the reproductive cycle. I think we also see it with a lot of chronic modern disease, right? So you have healthy levels of estrogen. Maybe Felice Gersh said this. She's like, you want to rent estrogen, not store it, right? So how do I get rid of my estrogen? I detoxify it in my liver. I eliminate it through my stool, right? So what is the statistic? Is it 40% of Americans have fatty liver? It's some obscene statistic,
yes,
right?
It's a very worrisome development, this metabolically associated fatty liver dysfunction and how prevalent it is.
Right. And so if you've got someone on a Western American diet, predominantly refined carbohydrates, they're ingesting more carbohydrates than their body can handle. At some point, we can't get that glucose into the cell. So then what does the body do with it? It turns it into fat and makes that visceral fat that you mentioned. It also makes fat in the liver. When I start depositing fat in my liver, my liver is where I detoxify everything. So not only can I not detoxify my estrogen, what else is going on in modern life, right? The average woman walks out of her house with 100 different chemicals on her body, right? So if it's fragrance in her dry shampoo, if it's cosmetics, if it's fragrance that she's putting on her body, if it's dry cleaning solvent, whatever it is, there are toxins in the water, there are toxins in the air, all of those things. We're not detoxifying those things either, right? And then
right.
Our
like a self-perpetuating cycle, right?
yeah,
We make more fat, we store more toxins in the fat, we load our liver with fat, so it makes it less likely for us to detoxify. So it's sort of like that vicious cycle of estrogen dominance that continues to raise the army of bad actors, so to speak, from within.
right. And then if our liver can detoxify it, we need to have enough fiber in our diets to poop it out, right? And so how many Americans, I mean, I don't know if you walk up and down the aisle at Costco, there's a whole aisle, right? There's a whole aisle of I either have heartburn or I can't poop, right? There's Miralax and all these things because people are eating a highly refined diet. They're not eating enough fiber. And so we need that fiber to bind up the excess estrogen and get it out. So we kind of think about detoxifying in our liver and eliminating through the bowels. All of those systems have to be working well. And then maybe another thing to throw out is another thing with modern life is polypharmacy, right? A lot of people are on 5 or more medications, particularly as we age. But I think younger and younger people are on medications. All those medications are going through the liver. So I kind of think about this really simply, and maybe I'm dating myself, but maybe when you were little, you played musical chairs at a kid's birthday party, right? And if we're trying to metabolize toxins or medicines, maybe there are only 5 chairs, right? And the more things we bring in to metabolize is like we invited 20 kids to the party, but there are only 5 to play musical chairs with. You only have so much space in your liver to metabolize things. And the more you give it can't do its job.
And the same is, by the way, true with regard to supplements, because I've been finding that, there are many patients who feel that more supplements is better. And I always try to explain that less is more, because your liver still needs to process all this supplementation. And, by the way, right now is a great time. If you are listening to us on your favorite podcasting platform, you may want to jump into the YouTube. There'll be chapters on YouTube, so you will find it. Dr. Polly will send us this extraordinary infographic. It's called Estrogen Dominance, where she has causes of it, everything that, she just mentioned, a lot of them on the left-hand side, and the symptoms. And I would say, with regard to cardiac symptoms, I would throw in, high blood pressure, labile hypertension, increase in peripheral arterial stiffness, certainly arrhythmias, and even, heart failure syndromes, especially heart failure with preserved ejection fraction. And a lot of it is driven by this ectopic adipose tissue infiltration of the myocardium, which of course is cued into insulin resistance and hormonal shifts. So really great infographic. And I love, Polly, how you sort of gave, in a way, an opportunity to evaluate where a person may be with regard to their hormones and actually make an informed decision, because there really isn't sort of like hard and fast rule, right? For example, I see a lot of patients with lipid issues and patients who are seeking to either minimize or stop lipid lowering drugs. Very often it's statin drugs. And when it comes to cardiac risk and understanding of, well, how does LDL cholesterol or ApoB or inflammatory markers influence cardiac risk, we actually have the numbers, and we understand that if we, figure out a person's risk, overall risk of vascular events, we may need to shift the numbers lower, and maybe for a less riskier person, the numbers could be higher. But we have good data to support us. When it comes to the land of hormones, we don't really, at least to my knowledge, and, please correct me if I'm wrong, we kind of don't have a go-to number or a rule of thumb the way that we do it in the land of lipids. So how would you here, assess a person's estrogen dominance and sort of decide where are they and, which strategies they're likely to need to deploy in order to reverse it?
Okay, so thank you for kind of laying this out, because I think you're right. I think that in terms of evidence-based medicine, we're still learning, and most studies done on menopausal women were really qualitative. Like, how do you feel? How many hot flashes are you having? And we were really stuck in that mindset from a research setting for a long time. And so I think it's a really important question of, if you're replacing someone's hormone replacement therapy to provide cardiovascular protection, where do they need to be? And I think I'm using expert opinion at this point, because I don't have fantastic data to pull on. So I'll just say that if someone comes in, we're always going to take a history, right? So if someone sounds really estrogen dominant, let's take that perimenopausal patient. She might say, maybe she's 46 and she's starting to have what she calls shark week periods, right? They're just so much heavier, so much more clotting. She's having a lot of breast pain. Her PMS symptoms are getting really bad, and her cycle is getting shorter, right? So that if I don't have enough progesterone to maintain the endometrium, that's 2 weeks of the cycle, I'm starting to think about a luteal phase defect. I'm starting to think that there might not be enough progesterone in the system. I always want to check for structural things, right? You don't want to have someone, we're going to detox your estrogen and she's really got a big old fibroid. You got to check that, right? And I usually start with blood because it's cheap and insurance covers it. I go to urine metabolites and fancy testing when I'm stuck. I usually start with less expensive testing and see if I can get the questions I need answered. And so we would want, let's say she had a 28-day cycle. We would measure her estrogen and progesterone in serum, and we would correct the units. So estrogen is going to be reported in picograms per milliliter, and progesterone is going to be reported in nanograms per milliliter. So this is really important. Remember back in, I don't know, 10th grade chemistry when you had to switch around those numbers? So let's say estrogen is 180 picograms, that would be 0.180 nanograms. Okay. So once you've got your estrogen and your progesterone both in nanograms, you put the progesterone over the estrogen, and a quote unquote normal range is giant, would be between 100 and 500. If
Wow.
it's low, right? So estrogen is dominant, the denominator is bigger, you're going to get a lower number, right? And so that's when you're starting to think about estrogen dominance. Now we know hormones change. Perimenopause is a roller coaster, right? So I'm listening to the patient, I'm getting the history, and I might follow this over a couple of cycles, right? I might get more than one value because things are changing, but I'm listening to her history in relation to the labs. We're not running everything on one lab, right? And so, and then if she's giving me some, I mean, we're going to look at, right, Dr. Druz and leaders like her in the field that are saying, hey, look, 1 in 3 women die of heart disease, right? So if I've already got a homocysteine level and maybe your homocysteine's high and I'm thinking she's not methylating well, that's when I might, okay, and maybe I've given her some B vitamins and we've supported methylation through, it's not budging. Then maybe I might do like a Dutch test, so a dried urine metabolite test, where I can see the estrogen that's been methylated, the estrogen that's not been methylated, and really kind of figure out more specifically what's going on in the liver. How can I help detox better, support methylation, support phase 1 and phase 2 detox in liver, and really get into the nitty gritty. But I would say most folks that I work with, we can get away with some really simple things, right? All of our functional medicine foundation. Are you eating enough plants? Are you eating enough fiber? Are you removing toxins in your environment? Have you eliminated alcohol? Are you filtering your water? All of these really simple things. And then sometimes giving micronized progesterone if we need to. I use a lot of broccoli sprouts because they're sulforaphane. So that's going to help phase 2 detox of estrogen. It's also a superfood, right? You're not going to hurt anybody by having them eat broccoli sprouts. Right?
That's right. Cool. That's right. This is so great, Polly. And then could you also, I have a ton of questions. So some of the things that I'm seeing with these patients and, the reason, first of all, let me give our listeners a little bit of a backstory. The reason why I call this whole phenomena estrogen explosion is because I have gone through one myself, and it was truly an explosion. And, it compelled me actually to sort of think it through and do some research. And, I'm going to put a very super, super early plug for a book that I'm writing. It will come out in 2026. It is called Longevity Switches, How to Age-Proof Yourself for Optimal Health, Wellness, and Vitality. And we will talk about estrogen explosion and testosterone tanking in that book so that you understand exactly what is going on. But, I have to tell you that very often when I see these patients, I sort of see, our typical, cardiovascular badness. And, we in cardiology right now talk about cardio-kidney metabolic or CKM. And this is what we're seeing. We're seeing labile blood pressure. We're seeing palpitations. We're seeing emergence of so-called stiff heart. It's defined as diastolic dysfunction. If you're measuring yourself, for example, with devices, I like my Aura ring. It gives me my heart rate variability. Honestly, going back, sort of retracing my steps when I was at the initial stages of this estrogen explosion, one of the earlier signs was lability in blood pressure and reduction in my heart rate variability. So I think as we go in time and we become a little bit more clued in to what data could give us, data that is easy enough for any person to generate of themselves, we may come to rethink some of these definitions, because this very crude definition, menopause is a year, is a day after 1 year of not having a period. The train had left the station a long time ago with regards to cardiovascular risk factors, metabolic risk, cognitive risk, detoxification risk. That's already been years in the making. Right. And so, and I think for a lot of women, and I have to tell you, because I have these discussions with the patients, and I wonder how you respond when patients give you sort of a little bit of I'm not going to say pushback, but their opinion, because a lot of women are still coming in and they're very much influenced by the study. And we know what that study was,
The
that
WHI.
yes, that's
Yeah.
so they essentially feel hesitant about evaluating hormones or even considering bioidentical hormonal replacement because of women's study that was essentially done in much older individuals and had so many problems. And we've been, unpacking that study ever since it came out, and really pointing out time and time again a lot of holes in the study and how it's less applicable to our current state of knowledge. But the point is that a lot of women are still hesitant and they don't really, see the link between the hormones and other conditions that they're experiencing, not just weight gain, but cardiovascular condition, cognitive condition. So how do you address it for those patients who may still be sort of influenced by this much older, less applicable research?
I think we need to be really, really clear. So the WHI looked at one formulation of hormone replacement therapy. And you already alluded to this. Typically, it was given much in women that were much older. And then the women, I think it's also really relevant with your expertise thinking about cardiovascular risk. The women weren't really symptomatic with hot flashes and night sweats, right? Because they were trying to make sure that they couldn't tell the difference between the control group and the treatment group.
And they were also older, right? So they were
the average age
significantly
was
older.
63, exactly. And so when we're thinking about hormone replacement in the modern era, right? Because this study was done like in the early 2000s, right? Now we're at 2025. Most of us are only ever going to give transdermal estradiol. So if we give estradiol orally, again, we're having first pass liver metabolism. We make our clotting factors in liver. There's a very slight increased risk in blood clotting. So like a blood clot in your vein that could break off and cause a heart attack or go to your head and cause a stroke. So there's a slight increased risk there. So we don't really use that anymore. The other part, the medroxyprogesterone acetate. So back up 2 steps. In the WHI, in the estrogen-only arm, and in that study, they used pregnant horse urine estrogen that was an oral estrogen from an animal. Okay, you're not a horse. We're not going to give you horse estrogen. Okay. In that estrogen-only arm alone, there was no bump in breast cancer. Okay.
Right.
In the Million Women study and the Nurses Health study, 15 plus years of hormone replacement therapy, no bump in breast cancer on estrogen only, even on the pregnant horse urine estrogen. Okay. When they added a synthetic progestogen, so it's not progesterone, right? It's a progestogen. It was called medroxyprogesterone acetate. They found 3 more women out of 1,000 over 5 years that had a bump in breast cancer. Okay. Now, I think Rachel Rubin and Peter Attia did a fantastic podcast on this, kind of clarifying that it might not even be that in the control group was underreporting breast cancer. And so it may actually be a flat risk. This may not even be statistically significant. But usually when I tell patients, okay, I'm never going to give you the hormones in the study, but I want you to let's dial down the fear for a minute. Let's just talk about numbers. Even if the study was right, which I don't think it was, 3 out of 1,000 over 5 years, right? And so I'll say to them, that's about the same increase in risk if you had a glass and a half of wine a day for breast cancer, right? So we know that alcohol is a carcinogen. We're not having, in my opinion, intelligent conversations about the consequences of alcohol. Okay.
That is so true. And I have to tell you that, one of the findings and then subsequent criticisms of WHI was that the intention initially was to show that these women would have fewer cardiovascular events, but that is not what happened. They had a higher rate of cardiovascular events. But a lot of those women, due to the fact that they were older at enrollment, already had established cardiovascular disease. And so then the thinking became that women with known cardiovascular disease should never be offered hormonal therapy. And I have to tell you that I 100% disagree. I think just the opposite. I think women who have cardiovascular disease, especially early cardiovascular disease, people like your mom who have early menopause are at increased risk. And we can find subclinical cardiovascular disease. We don't have to wait for a heart attack or a stroke.
Right.
We can get calcium score. We can look, right now we have AI that not only looks at coronary flow and coronary plaques, but in Europe, for example, they're already measuring the degree of inflammation and the fat around the coronary arteries. We can do vascular age screening with CIMT. We can do so much to identify this subclinical disease. And, considering the impact of hormones on vascular protection, on nitric oxide, and all the variables that fall into it, I think management of this should include some form of bioidentical hormonal treatment,
Yes.
depending on the patient, of course.
So I just wanted to circle back around. So that was the WHI on the Premarin and the medroxyprogesterone acetate. And you kind of alluded to this. So estradiol transdermally is going to increase nitric oxide. It's going to open up blood vessels, and that's going to help lower blood pressure, right? So I've seen the same thing that you've seen. Women are in the perimenopause, and all of a sudden their blood pressure goes up. All of a sudden their cholesterol takes a hit. And a lot of times if we can get them on a transdermal and a bioidentical progesterone, which is prometrium, you can get a bioidentical progesterone at the regular pharmacy. The other thing that's important, I think, from a cardiovascular standpoint, we've established that estradiol is good for the heart for a really long time. When you added a synthetic progestogen to it, it kind of undid some of the benefits. And so adding bioidentical progesterone is also a really smart thing to do from a cardiovascular standpoint. So what I tell my patients is, I personally feel like hormone replacement therapy has been scapegoated for women's breast cancer while we are dumping poison in our food supply and in our environment, not protecting us against climate change and all the health problems that causes. We're blaming women for taking hormones, which is factually inaccurate and distracting us from the catastrophic damage that's being done, that we're poisoning our environment.
Hi, everyone. It's Dr. Regina here. Many of my colleagues and I are noticing patients coming to us with self-ordered blood tests. When this trend started to gain momentum, I thought it would benefit many patients. After all, who doesn't want more access to health testing? However, I see that self-ordered labs often lead to more confusion and frustration for our patients. Patients are coming in with a pile of labs, and sadly, they're not better off for it. This is why we at Holistic Heart Centers have launched Heartwell Toolkits, a curated collection of blood and genetic markers that one can get at home, focused on heart and brain health, gives you all the data you need to make informed and actionable health decisions. The toolkits can be ordered at our shop on holisticheartcenters.com. You can find the link in the show notes. Use the code TESTING10 to get 10% off and free shipping. So what, could you sort of tell our listeners? Let's say, I have a couple maybe smaller questions. Number one is that what should be the next steps? Let's say a woman who is between the ages of, let's make it between 40 and 55, right? Somewhere in that zone is where menopausal transition lives. What kind of tests should this woman ask of her physicians? What kind of symptoms should she pay attention to? Kind of like the top 3 things that any person can do without spending too much time or too much money to begin to understand where they are in relation to perimenopause, menopause. Are they really estrogen dominant or not? Because, the hormonal replacement is, the strategy is very different for estrogen dominant patients versus patients who are not estrogen dominant. So that's my question number 1. My question number 2 is that where are we? What do you know about research that's currently in progress? What do we believe research will actually deliver to us? What kind of knowledge, the answer to our questions that potentially in the future may change the perception on using hormones for women, and sort of, put the WHI in a rearview mirror that it belongs to.
I think we're putting the WHI in the rearview mirror because, there are a lot of physicians, people like yourself, there are a lot of very kind of celebrity type physicians that are being pretty loud right now. I know that there was a group that met with the FDA to try to get the labeling off of vaginal estrogen, and online people are like, and when are we ever going to get our own testosterone? Hello, like we're so behind, right? But I think we're moving past the WHI. I agree with you. I still have to have some of that conversation with my patients. Most of my patients come in and say, I needed this 5 years ago, but let's go ahead and get started. In terms of your first question, what testing should we do? So I do, even though I'm a gynecologist, I love our primary care colleagues. So I don't want to throw our primary care colleagues under the bus. They are working under extraordinarily ridiculous circumstances, seeing patients for 12 minutes and being asked to do more and more and click more boxes for insurance companies. So not throwing those guys under the bus. Those folks are our heroes, and they're doing the best they can in a really challenging environment. But most women are not coming in with really great labs, right? So when someone comes in and they say, I have energy fluctuations, I have weight fluctuations, I have mood fluctuations. I want to
sleep disruption. I can't sleep anymore.
You want to check all the hormones, right? So what's going on? Get a complete thyroid workup, right? So I'm not just thinking, I want to get a fasting insulin. I want to get a hemoglobin A1C. I'm going to go ahead and order the apolipoprotein B and the advanced lipid protocol and all of those things. Because again, like you said, most women present with a heart attack. So, hey, if we're all about having the better second half of our lives, then we got to get serious and figure out what's going on. I will often check their day 19 to 21 estrogen, progesterone, and testosterone. And that's a luxury if they're not on an IUD and they haven't had an ablation and they're not on, checking hormones while you're taking birth control pills is useless.
Sure.
If they have an IUD or they've had an ablation, sometimes we can do an ovulation predictor kit and get it 5 days after that. But I want to, as we've kind of alluded to, all of these changes are happening at the same time. What's their liver function test? What's and am I worried about insulin resistance? Am I worried about fatty liver? What's their ferritin, right? Like I'm looking at kind of comprehensive labs in addition to their labs, because none of this is happening in a silo. It's all happening together, right?
Exactly. This is such a great point that, and a lot of these labs, patients often don't realize that they don't need to check 300 markers. They just need to check the right markers. And most of these markers, they're not esoteric. They are available through very common labs. I hardly ever had seen a situation where some of these would not be covered by insurance. Almost always they're covered by insurance. It's literally something that could be obtained in the course of an annual physical or annual GYN visit. Now, the problem, of course, starts is when physicians need to be prepared to interpret the laboratories and to give women some guidance with regard to what those potentially mean. And of course, that's a much, harder a bridge to cross. But I think, I just wrote my piece for Substack yesterday because a couple of patients sent me the AI interpretation of their stuff, so the piece is called ChatGPT and Poop, because one patient did send me his stool result interpretation via ChatGPT. So I think, we do have now additional opportunities, not that I advocate for patients to do self-interpretation for the blood work. I think that sort of citizen doctor activity has to be taken at its face value, but one also needs to understand that it creates issues and sometimes a lot of issues. But the point is that we now have access to more information than ever before. And, getting this blood work or even getting a symptom assessment and, telling your physician that you are experiencing these symptoms, looking at your biometric data. A study just came out in JAMA that showed that majority of patients who are suffering from high blood pressure don't know what their number is supposed to be that would be considered under control, and
Mm-hmm.
it's absolutely astounding that, and, one of the recent findings for us also, at least in my specialty, is that after many, many years of making steady progress to reducing cardiovascular disease mortality, the curve is now flat. And,
Mm.
and this is, one of my colleagues observed very astutely that we have more money, more devices, more tools in the system than ever before. And we're on the flat part of the curve. And what's even worse is that we're seeing other countries, let's say developing countries, with fewer resources catching up to us in that, cardiac mortality curve. So there is a lot, to consider. So any closing words, Dr. Polly? Any resources or anything that you would like our listeners to go and explore? Where can they find more information, sort of to educate themselves on this topic?
Well, I also have a podcast. It's called Menopause Rescue. And so here we're trying to kind of bring some of these issues up. I would give patients a shout out to let's interact in a mutually respectful way with our healthcare team. And what I mean by that is, let's say you get 15 labs back and you're expecting them to give you all the answers and a detailed explanation over messaging. That means you're asking them to work for free on the weekend or take time away at night from their family. Okay. So if you have a ton of questions, you absolutely deserve to get those answered. And the doctor absolutely deserves to get paid for their time and not be expected to do it during karate practice while they're driving their kid, right? And so make a follow-up appointment. I think that the healthcare system is absolutely broken and patients have every right to feel frustrated and they have every right to get their questions answered, not by a robot, but by a human being who understands their history, who has a relationship with you, right? So let's make a follow-up appointment. And then I also think that menopausal concerns are complex. They need a separate appointment from a woman's wellness visit. A woman's wellness visit is kind of a check the oil. Do you have cervical cancer? Do you have breast cancer? They're not thinking about a whole lot else, right? And
Right.
and it would be fantastic. The patients are busy too. It's hard to get out of work. It's hard to get to the doctor. Totally get it. But these issues, menopausal issues, sexual health issues, they all need time, and we're not getting adequate care. I think a huge part of that is not enough menopause literate healthcare providers. You can go on menopause.org to find a listing of menopause literate healthcare providers. But I would just encourage, you deserve to get your questions answered. You deserve to be taken seriously. You deserve to be advocate for yourself. Don't let your heart attack be your sign of cardiovascular disease, right?
That's right. That's right.
Know your numbers. What should your blood pressure be? Know what it is. So I think we're just entering into this really exciting second half of their lives.
Yes.
And it's going to take, we're going to have to work hard on this. We're going to have to exercise. We're going to have to lift weights. We're going to have to watch our liver health. But don't you think, Regina, we as midlife women, we are in the best place possible to get this stuff done. We know what we want. We can ask for
100%.
Right.
100%. And, I feel like we're at such an inflection point now where I think society as a whole is accepting menopause as a type of a transition that deserves attention, that deserves resources, and deserves to be something where we acknowledge what we know and what we don't know. It's no longer being swept under the rug. And I do think that, women who are in midlife, people I listen to a number of podcasts, and I love your podcast, by the way. So my listeners, please check out Dr. Polly's podcast. We'll have a link for you as well. I listen to a number of podcasts and people say, well, menopause, midlife pause, pause time. And, I understand what the creators are trying to present there, but I wish they say midlife power, because in midlife, comes the power, the power and the passion to actually pursue what you wish to pursue. You have experience now and knowledge from your earlier days, and it is real power to change lives, not just your own life, but lives of people around you. So, Polly, this has been phenomenal. I learned a ton. Our listeners, please check out Dr. Polly's podcast. We will have her estrogen dominance handout for you. Check out some of my episodes that have to do with or currently or forthcoming about LDL cholesterol, insulin resistance. We're going to specifically focus on a lot of metabolic issues, and hormones will come into it in 2026. And thank you so much for being on the show.
Thank you so much for having me. Thanks for all the work you do for women.
Oh, you too. You too, Polly. Hi to all professionals listening to us today. If you're thinking of launching a cardiometabolic or integrative cardiology program in your practice, we can help. At the Holistic Card Centers, we help docs in practice to expand into hybrid or concierge services. Head out to the show notes and click on the application link. Your intro call is entirely free. Ready to schedule a practice review? Use code DOC10 for 10% off our Practice Power Hour 16 minutes coaching session. The link is in the show notes. Thank you for tuning in to Own Your Heart Health with Dr. Regina Druz. This podcast is powered by Holistic Card Centers. If you enjoy the show, please rate and review us on your favorite podcast platform. To learn more about our services, visit holisticcardcenters.com and subscribe to our YouTube channel. The link is in the show notes. See you next week.